today. I really appreciate everyone joining. It seems like we're just really getting back into the full swing of things after the crazy holiday season, and takes a while to really get settled back in and things get back into a routine. Very pleased to be able to present today part 2 of a quality improvement presentation that is really designed for that newer staff member to the critical access hospitals. I have distributed the recording to the first session and hope you've been able to share that internally. It was nice to receive feedback from our last presentation that it was a very nice overview and that it was a good refresher for staff that have been in quality for a number of years. I do want to thank Allie Orwig with the Indiana Rural Health Association for supporting us in Zoom. She's always great to assist us. Everyone will be on mute, but you are able to unmute if you click off the little microphone beside your name in the participant list. And you're also welcome to chat any questions you have into the chat at any time, and I will work with Sarah to make sure that those questions are addressed. We also want to thank David Conrad and Joyce Fillenworth at the State Office of Rural Health for all of their support. So if you have any questions or you have any concerns or needs, please reach out to Joyce, David, and you can also contact me and I'll facilitate that message. So if they have resources that would be able to assist you in your concerns, why, they're always glad and always work very hard to see that needs are addressed. So we'll get started with today's presentation. I had shared earlier that today's presentation, along with a handout related to quality improvement self-assessment, was distributed yesterday around 8:30 for me. I am Becky Royer, and I assist the State Office of Rural Health with the MB-QIP program. So during this part 2 of our quality improvement presentation, we're going to build on the last session and also discuss some resources that are available to you. Again, all are welcome to stay. You're welcome to forward information, and I will send out the recording link, the presentation, and the handout when those become available. Our guest speaker is Sarah Brinkman with Stratis Health. Sarah has presented for us several different times on various topics related to the measure, data collection, and best practices around the Medicare beneficiary quality improvement project measures, and just really does a nice job of supporting all of the states on a national level. Stratis Health is a national support contractor for the MB-QIP program through the Flex funding. Sarah has a lot of great experience, and her specialties include quality improvement, grant writing, project management, meeting facilitation, professional training, community education, and a number of other areas related to improving the quality of healthcare in rural communities. So at this time, I'd like to turn it over to Sarah. And again, feel free to chat in your questions or unmute your line at any time if something arises. So Sarah?
Thanks, Becky, and thanks everyone for having me back. It's nice to be here. Those of you who have been on previous calls with me know that I'm a pretty informal presenter. I appreciate getting the opportunity to interact with you all, so I really do encourage you to jump in and chat, and when the opportunity arises to maybe ask questions over the phone as well. Becky did a nice job of orienting you all to who I am and where I'm coming from. You're familiar with us probably by now. We serve Stratis Health is the organization that I work for, and we work on quality improvement and patient safety primarily, with a long history of working with rural providers on those topics. And we serve as the Rural Quality Improvement Technical Assistance Center, so working with the 45 state flex programs. There are 45 of them because 5 states don't have critical access hospitals. And you can have a little quiz later to see if you can figure out which 5 those might be. But then we get to work with those 45 state flex programs, and you all as the critical access hospitals that are doing the work in the field to work on quality improvement for your patients. So today what we're going to cover, as Becky mentioned, is kind of a part 2 of looking at really how do you implement quality improvement, and beyond implementing a quality improvement project, how do you make it part of your culture? So not what you do, but how you do your work. Our objectives today are to consider some of the characteristics of a culture of quality, take some time to think through how you might assess the current state of your organizational culture as it relates to quality, and identify some short and long-term opportunities for improvement. We're going to look through an assessment tool together and talk about it, and then encourage you to take that tool back to your team and think through it as a group. So you won't actually be completing the assessment and identifying those opportunities today necessarily. You might get some ideas, but you'll have the tools and some of the resources to be able to assist you with that going forward. And then we'll talk about some strategies for embedding quality improvement into your organizational culture. So when we think about quality improvement, and this is a little bit of a throwback to what we discussed in December, if you were on that call or listened to the recording, before you can really look at embedding a culture of quality improvement, you need to come to an understanding of why do you want a culture of quality improvement? What does it help us to accomplish? So most of you are likely familiar with these 6 core concepts that are laid out here. They were presented in the 1999 To Err is Human report that came out from the Institute of Medicine. So our goal in healthcare is to ensure that we provide the right care for the right patient every time, meaning that that care is safe, effective, patient-centered, timely, efficient, and equitable. Those were the 6 key characteristics that were identified. Best practices or evidence-based practices direct us towards what the right care is, and what quality improvement does is help us to incorporate those practices into our work to ensure that processes are consistent, repeatable, dependable, that we really are working towards bridging the gap between knowledge and practice. And we talked about this when we met last time as well. You can see here kind of that visual representation of what we're trying to accomplish. You have what you know, which is your best practice and your clinical guidelines, and then you have what happens, which is your practice, and in between is that gap, and that's what quality improvement allows us to do, is really implement what we know to be the best clinical care and the best processes and the best treatment methods and all of those types of things into practice, so that our workflows accommodate making that happen, and that patients get the benefit of that that amazing amount of knowledge that your clinicians have by being able to actually put it into practice. So we also talked about last time just some foundations of QI, and I think it's worth readdressing here just real quickly, and also in case anyone wasn't on last time. So some of the foundational elements of quality improvement include that it's customer focused. Sometimes this means that it's patient focused. Absolutely, healthcare is patient focused. It's also important to think about who are your customers, not just from a patient perspective, but from an internal customer perspective. Who are you serving inside of the organization, in addition to who are you serving? Your primary focus is on your patients. So for example, if you're thinking about the lab, the patient is obviously one of the customers, but the department that ordered the lab is also a customer. And so kind of thinking about customers in maybe a different way than you have before. And thinking about what it really takes to really truly delight your customers. How can you go beyond just providing satisfactory care to providing extraordinary care? And how can you then also help your coworkers see how their work affects others in the process? So again, when you think about that chain and how things move along in a healthcare setting, one hiccup along the way can affect many others in the line, with the patient being the ultimate recipient of whatever that issue might be, but it does affect others in their ability to provide safe and effective care. We know that quality improvement is process-oriented. Everything that we do is a process, which is a sequence of steps that produce a desired product or outcome. And when we think about quality problems, a vast majority of them can be tracked back to a process or a systems problem. It's not about an individual person doing something. It's about the process being set up to be able to support people in the work that they are trying to do. So what we know is that well-defined processes help to reduce variation. So again, It's not what you do, it's how you do it. So you want to really be embedding quality improvement into your processes so that they can be consistent and efficient. We know that quality improvement is a team effort. It really requires participation from all of the stakeholders that act on the process. While individuals obviously contribute, quality improvement truly requires that there is a team and that you have everyone involved from leadership down to frontline staff, and sometimes even the maybe not usual suspects. So thinking about departments that may not always get involved or invited to participate in those types of quality initiatives. It's not just clinical care that needs to be involved, it's everyone on the team. And finally, quality improvement is data-driven. So data really is truly the cornerstone of quality improvement. The motto is if you can't measure it, you can't improve it. So you really need data to help you understand how current systems are working, to demonstrate what happens when changes are applied to current systems and processes, help identify what variations exist in the process, whether they're common cause or special cause, and so on. What it does is really helps you to monitor processes and progress on improvement over time. And what we're going to talk about today, one of the key pieces of embedding a culture of quality is being able to document successful performance, and not just document it, but celebrate it. So when we think about what happens in quality improvement, we know that teaching and understanding quality improvement concepts is pretty straightforward, but in practice it can be really challenging. There is no lack of issues that we can attempt to address, and we can often find ourselves in more of a just do it or get it done mode, which can result in not taking the time to thoughtfully define and prioritize our problems or plan and meaningfully monitor our solutions. So we can take a quality improvement course, we can have the best laid efforts. I know this happens to me all the time. You think about any process that you take part in, you think, oh, this is how I could maybe improve it next time, and then the next fire of the moment comes up and you don't necessarily have time to be thoughtful and intentional about your process improvement and quality improvement efforts. Sometimes it can feel faster to just do it. Especially, I know sometimes this can come up in terms of the concept or the key concept of quality improvement requiring that there be a team. Sometimes it's easier to be the person that just gets something done rather than trying to involve a team all of the time. But often what happens is that we get unsatisfying results or end up having to do rework because we didn't understand what we wanted to accomplish. We didn't get the buy-in of the necessary people. So in the long run, if you look on the right-hand side, what often happens is that we pick something to work on, we think of an option, we implement it, we hit system barriers, and we fail. And the reason that that happens is because we didn't take the time to do it correctly in the first place. Really what we should be looking at on the left-hand side is the ideal, where we're prioritizing our areas to improve using data to help us drive those decisions, analyzing the problem and understanding the root cause of the problem, which includes inviting other folks into the discussion. It shouldn't be just an individual making those decisions. It should be team-based. You're measuring your current performance against your goals, carefully and intentionally choosing an option to implement based on best practices or what you've learned from others, planning the change, implementing and testing the change in small tests of change through using something like PDSA, the Plan, Do, Study, Act cycle, and then evaluating your results and lather, rinse, repeat. You're going to work through that process and find your opportunities to work out kinks as you start to scope and scale the improvement efforts. But we know that even when you do that, even if you are very intentional and you work through everything, change is really hard. Quality improvement concepts can be simple, but change is hard. So when you come up against roadblocks, it's helpful to think about whether they are issues of the head, the hands, or the heart. Is this about knowledge? Do people need additional education, data, facts, more research, more journal articles, more models or case studies to review? Is it about skills? Do they need to have more workflow tools and things like that to help them through the process? Do they need additional training on what the process is supposed to look like? Or is it about the heart, which often ends up being one of the major roadblocks for change? Is it about their feelings and their motivation? Do they need to hear more stories about why this is important? Do they understand the why and the role that they play? Are they able to make connections between the work that they're doing and the outcomes that you have set as goals for an organization? And do they feel connected to those organizational outcome goals? And so what you really want to do as you're implementing quality improvement and embedding it, a culture of that, is make sure that in all of your quality improvement efforts, you're considering these things. And when you run up against a roadblock or something isn't going as it was intended or planned, quite often what we end up doing is trying to throw more training or education at it, rather than necessarily reevaluating and thinking about what might some of those other barriers to change be. And sometimes really we find that that feelings and motivation, the heart, is really where the roadblock stands. And that can be one of the more difficult ones to address, but at least if you know that that's what you want to address, you aren't throwing education at that roadblock. You can actually take some time and effort to address what that is within your system. So when we think about a culture of quality, there are some success factors. There are factors that contribute towards establishing and sustaining a culture of quality, and they're comparable for those that you need for sustaining improvement on an individual project. This is just on a broader level. So when you think about if you've implemented a quality improvement project and you want to sustain the gains that you've made, some of these apply on a micro level to that type of a project sustainability. But what we're thinking about here is a broader cultural sustainability around quality improvement being the way that you do your work. So first and foremost, it's essential to have leadership in the form of visible commitment, resource allocation, and accountability throughout the organization. It's really important that the processes for quality improvement be systematic. Everyone should be speaking the same quality language and using a shared approach to doing the work. Developing easy-to-use templates can help with this by keeping quality work organized and efficient. So you might think about having tools at the ready for the various units in your facility to utilize, so people aren't having to make it up as they go along or rebuild the wheel, and then that way all of your leaders are speaking the same language. Are you doing PDSA? Are you doing the model for improvement? Are you doing Lean Six Sigma? What does that look like, and is everybody speaking the same language? Quality improvement should be flexible, so be creative in how the work is allocated. A key idea here is to assign project team members and leads based not only on needs and capabilities, but based on staff interest. The people who bring forward the issue are often the folks who feel most passionate about it. They may not have the title, they may not have the educational credentials, or necessarily maybe even the quality improvement training all of the time that you would be looking for, but if they have a passion for what the issue is at hand, that's going to be more important than their qualifications or training any day. So you can teach people the skills, but if they have the heart for it, that's what's really important. Necessary to set clear expectations at the organization level that prioritize quality improvement for everyone. And that's in order to help distribute leadership and make sure that it is everyone's responsibility. There's a lot going on in hospitals, and in critical access hospitals, people wear a lot of hats. Patient care is obviously the priority, but it's important to ensure that quality improvement doesn't get lost in the shuffle. The adage of being too busy chopping wood to sharpen the axe comes to mind. So if we allow time to work on quality improvement, ultimately we'll enhance patient care. We don't want to be letting quality improvement fall to the wayside because it really should be the way that we do our work. And finally, and this is what I mentioned before, it's really important to celebrate and recognize wins. This will help people to feel appreciated and keep them engaged in the work as you move forward on future projects. The Institute for Healthcare Improvement identified 6 components of sustainability, which are listed here, and I think they serve as a nice bridge between thinking about sustaining improvement on individual quality projects, and sustaining a culture of quality improvement. So when you think about what you've done on an individual project and you think about embedding a culture of quality. So if we consider each of these, do you have a supportive management structure? Is there strong leadership support from the board and the executive team through management down to frontline staff? Are there clear lines of communication through all of these levels to ensure that everyone's on the same page? Does leadership take time to recognize the hard work of staff by celebrating successes? What does that management structure look like? Are there structures in place that help to foolproof change? Are you making it difficult to do the things the wrong way or the old way? If there are changes that have been implemented, is it easy to do the right thing? Is there effective documentation of updated processes? What tools have been developed or technology have been leveraged to support the new processes? And here, your electronic health record can go a long way in being a helpful tool if utilized properly. Are there transparent feedback systems and in such a way that everyone in the organization is aware of the goals and the current performance on the measures that they should be working on? Is it provided in a way that's meaningful for the audience that's reviewing it? Is it unit level for frontline staff so they can understand their role? And is it rolled up to the organization level for executive leadership? So the same data, same maybe measures provided in different visualizations and roll-ups based on the audience. Regarding a shared sense of the systems to be improved, does everyone involved understand the processes and systems they're aiming to improve and the role that they have to play in that effort? Is everyone clear on what their role is? And from kind of considering the broader sense of sustainability and embedding a culture of QI, does the organization share a sense of pride regarding the quality of their care and the work that they do to continually improve? Do they view quality improvement as part of their job? Is it written into job descriptions? Does everyone know how to bring forward an idea for improvement? Are staff actively engaged in the quality improvement initiatives happening within their departments? And finally, are there opportunities for staff at all levels to build their quality improvement skills through formal capacity building programs? So has leadership kind of put their weight behind that? Is quality improvement training valued as much as maybe, say, clinical training or financial training? Or do those opportunities exist? So I want to pause here, and I don't know, Becky and Allie, if we have the opportunity for folks to unmute their lines and just have a discussion around some of these questions. So this isn't the formal, and it's not really a formal assessment anyway. This isn't the assessment that was sent as an add-on. We're going to walk through that in a minute, but this is an opportunity for you all to just share and think through what are some of the ways that your organization is embedding a culture of QI or some of the opportunities that they have. So the questions that we have here, wondering if you can identify at least 3 examples from the past year where you have celebrated quality improvement wins, and what does that look like? How are you doing that? It can be as simple as a thank you note to an individual person. It could be a pizza party. It could be a lot of different things. And then the second one is, if someone from outside your organization was visiting, what easily identifiable artifacts would they see that reflect your organization's commitment to quality improvement? So if I come in from the outside, I don't know anything about your hospital, what kinds of things would I see that would indicate to me that you are committed to quality improvement? And that could take the form of things that are hanging on the wall. It could also mean maybe I'm doing kind of an audit to see what quality improvement looks like. Is it on the agenda at leadership meetings, at board meetings? Is there anything on your website? What does that look like? What structured method for implementation of quality improvement are you using? And this goes back to, are you a lean facility? Are you a Studer facility? Are you using PDSA? Is everyone using the same method of implementation and using it consistently? And how do you know that? And then how is accountability for quality improvement distributed? Who truly is responsible for quality? So these are some discussion questions, and I'd like for us to take some time to talk about them as a group if folks are willing and able to share.
And Allie, we might try to unmute the lines, but you can also unmute by clicking either by the microphone or the telephone beside your name in the participant list.
Yeah, I can absolutely unmute everybody. I just want to give everyone, you know, a quick heads up. If you are having side conversations or background noise, I'm going to unmute all the lines now, so you'll want to remute yourself.
Great, thanks, Allie. So I welcome folks' thoughts on any one of these questions. I like to cover all 4 of them, but whoever is the daring and willing person to go first will jump in wherever you feel is appropriate.
This is not a quiet group, so please speak up. I might share, though, that a question was sent to me through email that wondered if you did, while people are unmuting, maybe if you could address, you've talked about celebrating, but their question was around, do you have any suggestions or approaches that can make the data collection be more positive? Such as so that it doesn't appear as if the quality improvement team is always looking for problems and gaps.
Yeah, so that's a great question, and I would open that up to the group too to see what their thoughts are as folks who are doing the work on the ground. Some thoughts that I would have around that is it's helpful if at least a few of the measures are identified by the team that's actually responsible for improving on them. So, you know, there are measures that you are mandated to work on or that come down from leadership, and so folks kind of feel the pressure of that coming at them as opposed to necessarily being something that they're interested in. One, and that can help, you know, it can help to have some that you're doing really well on your performance board in areas where you have opportunities. We tend to, once we've reached a goal, remove those measures. If you have, you know, if you're tracking on things, it's still there in the background, but you're not paying as close attention to it once you've achieved it. And so it is important to celebrate, but I think, you know, you can kind of keep tabs on it or maybe provide updates along the way to show that not only did you achieve that goal, but you were able to maintain and sustain that level of performance. Another thing that I have heard has been helpful is encouraging departments to think about using quality improvement and data collection as a means for helping them to make the case for something that they want to do, or whether that be implementation of a new program, maybe a type of resource that they're looking for in terms of technology or that type of thing, that they can use the QI methodology to help demonstrate what their needs are, and make that appeal to leadership for resource allocation. So an example that I heard recently was of a physical therapy program for kids, and they used the QI methodology to really set their baseline. They did a pilot project. They were able to show that this particular program that they were looking to do had benefits across a variety of areas. You know, I think they considered patient outcomes was clearly a primary focus, but they also looked at staff satisfaction, they looked at financial, they looked at some other things. And so they were able to make their appeal to leadership for resource allocation for implementing that project broad scale because they used the QI methodology to demonstrate their need. So that's a couple of quick examples or ideas that I have, but I would welcome others in the group to weigh in, and the person who asked the question, whether or not that hits the mark or resonates.
Hi, this is Jill at Greene County. Can you hear me?
Yes.
I can answer a couple of these. First of all, we have great senior leadership backing us on any quality project that we want to do. And some of the celebrations that we do annually, I have a quality fair. So all the positive things that have happened throughout the year, it's a mandatory, every employee comes to it. So we do like a slideshow presentation, and we kind of have a little bit of a celebration of everything we've done. But through the year, we send thank you cards and give candy bars and we always make sure every month at our medical staff and board meetings, we are talking about something positive that we have accomplished in quality. When you walk in our building quality, you know, that's a great question. I was just sitting here thinking to myself, if I walked in, how would I know we were doing anything great? And I don't know from the outside looking in what we're doing. So that is definitely something I need to start thinking about to change. Anyway, that's my 2 cents.
Wonderful. Thank you so much, Jill. I appreciate you sharing. That's great. I think even those little things where, you know, you talk about something that is going well can really go a long way in not making people feel like everything's going wrong. So, you know, having that kind of moment for positive reflection during meetings can be one way of celebrating your wins, for sure. Thank you for that. Other people's thoughts with regards to Jill's last comment there. If someone came in from the outside, I know I've been to multiple facilities where their performance data is hanging up in the hallway. So I'm there visiting my family member, and I can walk out and because I have a particularly keen interest in quality improvement, I can make sense sometimes, maybe more than the average patient or family member would, of the data. But there's patient experience data that's hanging up in the hallway. That's where the team does their huddle to look at their quality metrics, is out in the open and transparent. Is anyone doing anything like that?
This is Peg. Can you hear me?
Yes, I can.
Oh, thank you. I've been trying to be heard for a little while. I'm sorry, I didn't see something wrong with my phone.
Thank you.
But anyway, at Pleska Memorial Hospital, what we've had is organizational improvement teams. And so what we had was to celebrate the wins of those organizational teams is we had like a little gallery set up of our projects and the outcome or the data posted, celebrating wins. We gave out little prizes. We had, you know, each individual group that presented their individual projects and their wins. They gave out little prizes, booth prizes, that sort of thing. We had little videos that we showed about the efforts of the team as the year had gone on, and showing them interacting on team events. So it was attended very well, actually, by the entire hospital. And so that was one way to celebrate the wins. We've also had, when we've met certain goals that would be organizational-wide goals, we've had like cake, or we've had pizza parties as a total organization with everybody invited, those sort of things.
Wonderful. Thank you. Those are great examples. And it makes it fun, right? So folks don't dread when the quality improvement person comes to the department because they know they're doing data collection to the previous question. They can, you know, they can appreciate the support that they receive and the accolades as well. Other thoughts on any of these or examples from your organizations? Well, what I would encourage you to do is to think about these questions. These are not necessarily built in to the assessment that we sent in verbatim, but the kind of concepts are built in. What I want to do is switch gears real quick and look at that assessment. So I'm going to exit out of this and open up the Word document that was sent to you all. So again, you could do this on your own. What we would encourage you to do is to think about doing it with a team and really kind of rating yourself. It's just a really simple 5-point Likert scale as to how well something resonates. Do you strongly agree that your organization's doing it, strongly disagree, or somewhere along the line? And what it will do is really prompt you to start to think about what opportunities you have. So the first page here is that kind of Likert rating and asking you things like, is quality improvement utilized as a method for approaching decision making and problem solving rather than considered a distinct or separate program? So again, that goes back to that example of, do folks think about using quality improvement for making their case for something that they want to do, and using that methodology to demonstrate what a program or a new technology or a new resource could do for the team? You know, are they using it in creative ways, and or is it really just considered, hey, quality improvement is that department over there, and it's that person that wears that title? Is the governing board engaged in quality improvement, and how would you know that? So again, to that question about if I came in from the outside and kind of did an audit, is quality improvement on the agenda for the board meetings? Is it a regular topic of discussion? I have heard everything from, no, it's not at all. Quality, they're only worried about keeping the doors open and interested in finance, or all the way up to some critical access hospitals that have done some really cool things in terms of engaging their board, and the boards participate in quality rounds with the quality director. Once a year, every board member goes on rounds with the quality director to kind of get a sense for what does it mean to be checking in on our patients and seeing how things are going, and what does it mean to stop by the unit department and look at their quality boards and see what their opportunities are and check in on folks. So you can really see a broad range of this. Are there consistent expectations for staff to be involved in QI? What's the process for ensuring that time is available for staff who are asked to work on QI teams? So, you know, you're a 1.0 FTE and you have a full-time clinical load, and now you are asked to be on this quality project as well. How are things kind of shifted to ensure that you actually have time, again, to sharpen that axe and make sure that we're doing things efficient and effectively? Is training available for staff? Is QI an integral component of new staff orientation and training? That's a key time when we really have a captive audience to be able to get folks on the same page. Are we using consistent structured method? Again, the example here is PDSA, but there are other examples. Are you using, you know, lean, those types of things? When you're looking at QI opportunities, are you focused on making changes to systems and processes rather than addressing individual behaviors? And for anyone who's done any type of education or participated in any trainings around just culture, you'll understand that it's really about the processes in place to make it so that people can do the right thing is the easy thing. And it's not that most people who work in healthcare because they care and they want to do the right thing. So are we making it easy for them to do the right thing? Have you identified sources of data and information relevant for use in quality improvement? So are you looking at data that reflects measures of clinical care, the services provided by your organization, input from patients, families, and caregivers? And are there strategies and processes in place to ensure that quality improvement efforts are broadly communicated and discussed across all levels of the organization? So this allows you to do some self-reflection and assessment. And then the second page includes some discussion questions. So once you've done that kind of assessment, what are your strengths? What are you doing really well at? And what should you in turn then celebrate? What are the things that you guys have really done a great job of embedding, and you need to take some time out to be appreciative of the fact that that's the case? And then what are your opportunities, and how do you want to go about identifying how to improve on those opportunities? Are there any themes that came out? Are there things that are connected? And then kind of coming up and using quality improvement processes to develop your plan for how you're going to go about improving that, embedding quality into your culture. So the last question there, what strategies and supports will you need to support change? Are you looking at knowledge? Are you looking at feelings and motivation? Are you looking at skills? So is it head, heart, or hands? What is it that you're going to need to be able to make gains in that area? So this is something we encourage you to take back with your team. We welcome feedback on it. And if there are things that you think are missing that we should be considering, or something that doesn't resonate, please pass that along to Becky or let me know directly. We'd love to hear from you. So I want to shift gears just a little bit to talk about one of the ways that you might consider organizing your work in quality in order to be successful in these other efforts. So we are strong proponents of what's called the hub and spoke model. this you can see in this kind of graphical format is where you have a quality or patient safety committee or whatever the equivalent is at your facility in the center. And then the spokes are the various quality initiatives that you have going on. In this case, we used some of the MB-QIP measures as examples. And the idea here is really around that distributed leadership. So you might have an individual or a group of individuals at the center who are responsible for making sure that things move forward as a whole, but that doesn't mean that those individuals are responsible for everything that needs to happen. You can have that kind of committee at the hub, and then the spokes can be other folks who are responsible for implementing quality initiatives and change. So in this model, what you have is a coordinator that keeps quality improvement activities moving forward, a central committee that plans, reviews, and oversees your quality improvement work. And then before and after those committee meetings, the coordinator might communicate with the leaders of those various spokes to get updates and share committee requests. The spokes then are the project or topic owners, and again, passion is essential here. Passion trumps almost any other qualification in choosing those leaders. You can teach people skills, but you can't teach them passion. So if they feel very strongly about a particular project, antibiotic stewardship, patient experience, those types of things, then they're going to be your go-to folks. You want to be creative in project delegation and make sure that the work is being spread appropriately. And it can really be any quality project or topic. Some of the suggestions that we have, obviously, we feel strongly and passionately about MB-QIP, so we always put that at the top of the list, but you're probably participating in a lot of other quality initiatives. The Hospital Improvement and Innovation Networks through CMS Partnership for Patients. Are you looking at conditions of participation and some of your regulatory requirements? What does quality look like in your facility? And then the spokes are responsible for reporting progress to the coordinator prior to those central committee meetings. Some of the success factors for using this model is that you're flexible. There is no perfect way, so be creative in how you allocate the work. You might have the same person who's responsible for multiple spokes, or maybe every spoke has a different leader. It just depends on what your team and your capacities look like. But you need to look at what makes sense for you. And what it does is allows flexibility and engagement of a wide variety of staff in project planning and implementation. And one of the things that we want to go back to here on that self-assessment is when someone is noted to be responsible for a quality improvement activity, is that taken into account with the rest of their, the volume of the work that they have to do? So if those spoke leaders are taking on responsibility related to quality, is there some give and take in regards to their other responsibilities? It's really essential that you have leadership engagement. You hear that all the time with anything quality related, that they have a visible commitment, again, that they're allocating resources, which can mean people's time, and that they're supporting accountability for everyone involved in that hub and spoke model. Things should be systematic. Common language and approach, using templates can really help so that everyone who's in those different spokes is using the same communication templates to share back what the outcomes are of their projects. And that helps you at the center potentially be able to track on things. It also helps to be able to translate things to leadership and the board. And that the flow of information really is between the hub and the spokes is critical. You want to be keeping a pulse on what's happening in those individual projects. You have to have some expectations that prioritize quality improvement. Really, this is a distributed leadership model. This model allows you to help distribute leadership in a way that's tangible for folks. It's everyone's role and responsibility. And again, make sure that folks are not allowing patient care to consistently trump quality improvement work. Are you too busy chopping wood again to sharpen the axe? So you all as quality folks, what's your role in this? You really want to be the leader that you would want to follow. You want to make sure that you are, walking the walk and talking the talk. You want to be putting quality improvement on the agenda. Make sure that it's in front of folks consistently. Make sure that the focus, again, is on those systems and processes, not on individual people, but that the systems and processes are set up in such a way that makes it easy for them to do the right thing. Encourage and welcome ideas for improvement. If someone has a suggestion, jump on it, take it. That I think will go a long way towards helping with some of that data collection fatigue too. If people are doing something that they feel is meaningful, they're more likely to buy in. Show respect for the perspective and the experience of others that are involved, and then celebrate, highlight and communicate successes and engagement whenever possible across all levels of the organization. And that takes us through what I had prepared for today's remarks, but I welcome the opportunity to have further discussion or any feedback or questions folks might have.
Thanks, Sarah. One question that was chatted to me was to ask you to further clarify common cause and special cause, and how would you communicate that with staff most effectively?
Yeah, so, and Becky, you could probably answer that too. So common cause and special cause, thinking about when you're looking at data and you see that there is a blip in the data, and you're thinking about, well, why did this particular case go this way? Was it common cause, and therefore is something that we need to address within the system? This is something that could happen again and is likely to happen again. So things that come to mind are maybe medication errors based on similar labels. So, you know, someone in the emergency department grabs it out of whatever your, I always go toward brand name labels based on my previous experience. I don't want to do that. But whatever your center is for taking the meds out, and they grab the wrong one because it's right next to another one that looks exactly the same because the labels are the same color. So when you see that issue happens, and maybe it happens frequently, you can say that that's a common cause variation. It's outside of what we want to have happen, but it's likely to continue to happen. And so we need to take a systematic approach to addressing that. What might be special cause would be, say, you have, I'm trying to think, like an environmental issue, you know, an environmental thing happens. So you have a tornado that rips through town, and your emergency department doesn't have the capacity to meet all of the needs that you have. You certainly want to try to find out what are things that you could do to improve, but you don't have a lot of control over that special cause that caused things to maybe go haywire. Does that make sense? Becky, do you have other examples?
Yeah.
I'm kind of blanking off the top of my head.
Actually, I was going to say a flood, because that is something that has happened. Yeah.
I'm trying to.
Yeah. And I think you did a nice job of really clarifying the difference between the two. And I think with a special cause, you just have to really evaluate, is it something that's going to happen again on any kind of reoccurrent basis, that you could really implement something that would prevent it from happening in the future. And if it's so extenuating, it may be that it's not a good good use of the quality improvement staff's time to really spend on addressing it. So you really just do want to evaluate it well. And then oftentimes when displaying data, sometimes if you put some of those anecdotal notes in the data as to common cause or those special cause situations, I think that that's very helpful. But Sarah, I think you did a nice job of describing it.
Thanks. And there are specific data visualization tools that you can use. You can use a control chart to be able to help identify special and common cause. The other kind of consideration there, to which Becky was speaking to, is, and that's the reason why you want to identify as a special or common cause, is what do you want to put your efforts toward? And you kind of want to use that 80-20 rule. So if it's going to happen less than 20% of the time, but you have other causes that are going to happen 80% of the time, you want to be focusing there. So you kind of, that Pareto principle is the idea behind that, if you want to Google it and find out more. But that's the idea. And we do have a resource available specific to the MBQIP data reports that helps you walk through those reports that you receive on a quarterly basis and give some examples of what might be common cause or special cause variation as you're analyzing your data reports and trying to identify opportunities for improvement.
Another question that was just posed to me, and I think this is a good one, and I welcome others to interject here, is Sarah, do you have some good ways to, the hospital likes to include staff in data collection, but incorporating data collection that aligns and is conducted while they're doing their work, not that something that they have to go document someplace separately or step away from, say, patient care in order to collect data or help submit data, I guess.
Yeah, so I would welcome others to weigh in too. A couple thoughts that come to mind is if you can make the data collection part of what assists them in doing their work. So I think of like of checklists, for example. If you're doing bedside rounding and you have a checklist for bedside rounding and they actually are using that as a tool in conducting their work, then it makes it really easy for them to fill it out as part of a data collection process. Another thing would be leveraging your electronic health record as much as possible to assist them in reminding them what the workflow is, and then by virtue of reminding them, if they can check a box or something that shows that they did what they were meant to do for that data collection purpose, that can be a tool as well as a data collection method. I don't know if those were the types of examples you were maybe looking for, if others have other thoughts. And if that doesn't hit the mark for what you were considering, please do weigh in.
Absolutely. And actually, that was the last question that had been sent to me. So if anyone has any others after today, why certainly send those to me, Becky Royer, and I will be glad to either answer it or search for a good answer for you. I do want to comment again that I will also be distributing the link to a lot of quality improvement basic webinars that Stratis Health has available out on their website. Some of them do a wonderful job of providing guidance on data collection, how to display your data, what particular type of graph maybe to select for the data that you're collecting, and just a lot of other good resources and tools that will help expedite your process and hopefully make your job a little easier. So I'll make sure to reshare those links so that those are available to you, as well as the recording for today. So, okay, well, I think that covers everything that we wanted to today, and we certainly welcome that if there are any other topics you would like for us to cover, we'd be glad to do that. So we'll conclude then for today, and I want to thank Sarah for sharing her wealth of knowledge and being a resource for us, as well as Ali Warwick for supporting Zoom so well for us today. Have a great afternoon, everyone.